Hey guys, this is going to be our lab information for this week. This is our lab on the effects of exercise on blood pressure. So we've been talking a lot about blood pressure, and this just goes over some additional information about it that we would have covered in lab. And you're also going to have a lab activity that's going to be posted to Moodle. So this is the PowerPoint that's posted. And what you have also is your lab outline. And so this is posted to Moodle as well. So you're going to want to have that with you because that's how we're going to go through the information. So here we go. Blood pressure, we've defined this before. And this is basically your hydrostatic pressure where you have pressure of the blood contained within the vessel, and it's basically pushing out in all directions and creating that hydrostatic pressure. So that is, in essence, blood pressure in our circulatory system. So blood pushing out against the walls of the blood vessels. And what we've seen too is this general trend where we have increasing pressure that's in the arteries closest to the heart. And then what you see is this general trend of decreasing pressure as we move from the heart further away. Capillary beds, pressure is going to be pretty low in terms of protecting those capillaries from damage because they're very thin and they can't handle high pressure. And then on the venous side of things, we have our pressure getting even lower all the way down to about 0 at the right atrium. So this does a few things for us. It does create a pressure gradient, which allows blood to continue to flow. And here I'm reminding you too that pressure in the right atrium is all the way down to 0 so that blood can flow in and return to the right atrium through the vena cava. Okay, so how do we take blood pressure? We use a stethoscope, which is going to be this guy here, and then we use a blood pressure cuff, otherwise known as a sphygmomanometer. And this is routinely how we take a blood pressure. In a clinical setting, we typically take it at the brachial artery just because it's close to the heart, so it gives us a good representation of the pressure in the heart, and it's easily accessible in a clinical setting. So that's how we do it. Blood pressure is measured in millimeters of mercury. And so the only thing I would add to this is that it would actually be millimeters of mercury, which is going to be a capital H and a lowercase g. So that's on me. Correct that on there. So that's how we express our blood pressure. How do we measure blood pressure? So when you have your blood pressure measured at the doctor's office, how are they figuring out what they're listening to? So basically what they're looking for are called the sounds of Korotkov. Okay, and so what happens is they're going to inflate the cuff. Here's a picture of our brachial artery, and the clinician is going to inflate the blood pressure cuff to a pressure that's higher than your systolic pressure. Okay, it needs to be higher than the top number of your blood pressure. So if your systolic pressure is 120, that clinician is going to need to increase that pressure in the cuff to something higher than 120. It doesn't need to be significantly higher, but the problem that you run into is you don't know what their systolic blood pressure is going into it. So you're going to want to increase the blood pressure cuff, up maybe 160, even 180, so that you can be sure that you're catching that systolic blood pressure as you're coming back down. So what happens is you increase the cuff, and this basically occludes all the blood flow in that brachial artery. So you're actually just pinching it all off so nothing is traveling through. Then you start to release the pressure on the cuff, and as you start to hear the sounds, you at that point have lowered the pressure in the cuff to the point where you're now at the systolic blood pressure, the highest pressure in that patient's circulatory pathway. So there's your high point. And so that's going to be your systolic blood pressure. when you hear that first sound. Okay. Now you're going to continue to lower the pressure in the cuff all the way down until you hear the last sound. Okay. When you no longer hear the sounds, what you're going to hear is it's kind of like it almost sounds like the heart sounds. When we talked about that with the heart, like the lub dub. So you're going to hear kind of this whooshing sound, like, okay. And after you hear the last sound, that's going to be your diastolic blood pressure. Okay. And so if we look here on this line here, let me get rid of, yeah. Okay. So if we look, here's our pressure. Okay. And this line right here is showing you your cuff pressure. Okay. So I've inflated my cuff, and as you can see, I've inflated my cuff above the level of their systolic blood pressure. And again, that's just that's a judgment that you have to make because you don't know what their systolic blood pressure is going in. So you're going to inflate it higher, and then you're going to slowly release. You turn the valve to release the pressure in the cuff. So the pressure in the cuff is going to slowly decrease, and as it starts to line up with the systolic blood pressure, with that high pressure in the patient, there's your systolic number that's going to go on top. We continue to lower the pressure in the cuff. Once we no longer hear any carot cough sounds, which is kind of showing you here, each one of these is going to be a carot cough sound, and we're going to hear it every time the heart beats, right? It's going to correlate with those pressure changes. That is going to be our diastolic blood pressure when we no longer hear the sound. Okay, taking blood pressure is a skill. I mean, you certainly can't teach that on an online PowerPoint. So that's just something that, we would need to get our hands on blood pressure cuffs and practice it in the lab. So, but we've got a lab activity that you're going to be able to do. So that'll be good experience too. Here's our systolic and diastolic blood pressure. So again, we've talked about this in a couple different formats, but systolic blood pressure, again, being the top number, it's the blood pressure during ventricular systole, so it's going to be our high point, averaging about 120 millimeters of mercury. But we certainly know that there's patients coming in with much higher pressure than that. So in a clinical setting, you're going to see numbers that are higher than this. Diastolic blood pressure is the bottom number, and it's going to be the low pressure. It's the pressure in the vessels during ventricular diastole. So this is going to be your lowest pressure on average, about 80 millimeters of mercury. Again, in a clinical setting, you're going to see it, and it's going to be a little higher than that oftentimes. So pulse pressure. This is basically the difference in pressures. So when we look at pulse pressure, we have this equation here. So pulse pressure equals systolic blood pressure minus diastolic blood pressure. And this is your pressure gradient. Okay, so this is the difference in pressures. And we know that the pressure gradient is what drives blood flow through the circulatory pathway, because blood's always going to flow from an area of higher pressure to an area of lower pressure. Okay, so the more gradient we have, the faster that blood is going to flow. So pulse pressure is the difference between the two, and we can actually take that and, like, if I gave you a number for systolic and diastolic pressure, you would need to be able to calculate pulse pressure. And it's simple subtraction. I've got an example here. Let's say we've got a patient with a systolic blood pressure of 132 millimeters of mercury. They've got a diastolic pressure of 92 millimeters of mercury. We subtract the two, and their pulse pressure is going to equal 40 millimeters of mercury. Okay, so it's as simple as that. Pulse pressure, again, is the pulse that you feel. So when you palpate like carotid or radial, and you feel that change in volume, that you're actually palpating the pulse pressure, the difference between the two. Okay, there's another calculation that we can make as well, and this is called mean arterial pressure. So mean arterial pressure is basically an average pressure during each cardiac cycle. Okay, so if you remember, one cardiac cycle is one heartbeat, right? It's going to be diastole and systole, and that's one heartbeat. Okay, so there's one cardiac cycle, one heartbeat, and we know that the pressure in the aorta is going to vary. It fluctuates and it pulses up and down because pressure in the aorta is pulsatile. So we're basically going to see these pulses like this, where our high point is systolic and our low point is our diastolic pressure. Okay, so one of the things that we're going to be able to calculate with this is called mean arterial pressure. Okay, and what this is the average pressure. So we also want to keep in mind that our average pressure, it's not the halfway point in between the two, because our heart spends more time in diastole than in systole, so our mean arterial pressure is going to be a little bit lower than that. So like this would be our line of mean arterial pressure, a little biased down towards the diastolic pressure. And I feel, yep, that's what we see here. Same exact thing. Here's our pulsatile pressure changes in our larger arteries. Here's our systolic at the top. Here's our diastolic at the bottom. And then this line here would be our mean arterial pressure. And as you can see, it's a little biased down towards the diastolic side of things. Okay, so how would we calculate that? Here's your equation. Here, there's actually a few different equations. So if you don't like the one that I'm giving you, it's fine. You can always find a different one as long as you end up with the right answer. It's fine with me. But this is the one that I learned, so I just kind of stick with it. But here's our mean arterial pressure. And we can calculate that by taking diastolic blood pressure and adding it to pulse pressure divided by 3. Okay, so our pulse pressure is this pulse pressure, right? We've already calculated that. So let's take a look. If we had a patient with our initial blood pressure of 132 over 92, okay, pretty typical. Diastolic's a little high, but okay. If we calculate our pulse pressure from that, we know if we just pull this forward from our previous slide, we calculated here a pulse pressure of 40. Okay, so we can just use that. So if we plug all that into our equation here, our mean arterial pressure is going to equal 92, which is our diastolic blood pressure, plus 40 divided by 3. Okay, and we know that we're going to calculate this first because it's in parentheses. PEMDAS, right? So 40 divided by 3 gives us 13, and it's fine to keep it at a whole number. So we would say 92 plus 13, which is going to equal 105. Okay, so this person has a mean arterial pressure of 105. Our units would be millimeters of mercury. Okay, and so that's how you calculate it. So if I were to give you a blood pressure, a systolic and a diastolic, you would need to be able to calculate mean arterial pressure. Okay, so what do we do with that number? What does that tell us? Well, we have a normal range of mean arterial pressure, and that's from about 70 to 110 millimeters of mercury. Okay, so that's typically what you see. And so if we base it on that, our patient here with their mean arterial pressure of 105 falls within that normal range. So we would say they're absolutely fine. Now, where we run into trouble is if we have a mean arterial pressure that is less than 60. Okay, we need at least 60 in order to perfuse, and that is kind of our technical word for adequately supply blood to tissues and organs in the body. Okay, and so we need a certain amount of pressure. And it's that same example that we've used before with like the soaker hose. So you've got higher pressure at the beginning of the soaker hose with all the holes in it, lower pressure as you travel through. When you get to the end of it, very low pressure, not a lot of water coming out of it. You don't want your brain on that end of the blood vessel, right? Because it may not get good blood flow like it needs. So we do need a certain level of mean arterial pressure in order to adequately perfuse vital organs in our body. Okay, so brain and kidneys and the heart. Okay, so those ranges are important. Been over that. So now what happens to blood pressure when we exercise? And so we have a few things that are going to change here. So one of them is cardiac output. Okay, and we've defined this before. We know that cardiac output equals stroke volume, or how much the heart pumps with each beat, times heart rate, or beats per minute. Okay, and so this is how we can calculate, flow to the body, that cardiac output. So cardiac output is going to increase to supply all of our working tissues with adequate blood flow, oxygen and nutrients. Okay, so cardiac output is going to increase to meet the increased metabolic demands that we have during exercise. Okay, so that's one change that we're going to see. We do have an increase in stroke volume. So we have increased venous return going back up to the heart. All those muscles pumping is going to increase venous return, which is going to then increase stroke volume. So that increases pressure on the walls of the blood vessel, pushing out, and we know that that's going to increase systolic blood pressure as well. Okay, so that's going to be an increase in hydrostatic pressure, which results in an increase in systolic blood pressure. Now, here's where we can see a little bit of a difference. During aerobic exercise, typically what happens is you may see a decrease in your diastolic blood pressure in that low pressure because we have kind of a pervasive vasodilation throughout the body as blood vessels vasodilate to supply working skeletal muscle with blood. Okay, so during aerobic exercise, one of the changes that you're likely to see is that diastolic blood pressure will actually decrease. Okay, and that's just when we have vasodilation, those arteries open up and create less pressure because their diameter just increased, their resistance just decreased, and then pressure decreases. Okay, so during aerobic exercise, systolic will increase, diastolic will decrease. Okay, now during weight training, like if you're doing resisted exercises, so you're going to the gym and you're lifting, we actually see something different. So diastolic in that case tends to increase, and that's because we have contraction of the muscles, and we know that a lot of arteries, especially the deeper ones, are embedded within layers of muscle, and so they can be compressed by those working muscles, and that in essence creates vasoconstriction because those arteries are being compressed. That's going to increase resistance and therefore increase pressure. Okay, so just think about those relationships that we've talked about before. So during weight training, typically diastolic blood pressure will increase and systolic blood pressure increases as well. So some differences there between the two. Okay, all right, so that's blood pressure. Let me know if you have questions and we'll keep it going. Thanks.